Welcome to the First Principles of Medicine podcast. In this series, we will be breaking down complex medical topics into their first principles. When the stress is on and you've just been asked the tough questions you don't know the answer to, we feel you'll be able to fall back on these principles to formulate a decent answer and reason your way out of trouble. Today we have Jason presenting Pleural Effusion, and we have a special guest today, Mo, who is a lifelong listener to the podcast. Welcome, Mo. What do you have to say about our podcast?
I've been a lifelong listener and I've been enjoying it. Helps me on my drives.
I just want to clarify. It's lifelong for the life of the podcast, not Mo's life, right?
So a period of like 2 months.
Yeah, I was good. Lifelong. Yeah, right, cool.
Anyhow, welcome. Love to have you on. If you're a listener right now and you want to be featured on this podcast, please get in touch and we'll see you soon. In the meantime, take it away, Jason.
Cool. So pleural effusion. Let's run through some of the first principles. So to understand pleural effusion, we're going to bring it back to the anatomy of the lung or the anatomy of the pleura. So I'm going to ask some questions. Can anyone tell me what the visceral pleura is? Just a very basic definition.
I reckon you know.
The inner pleural membrane.
Yeah. So it's the membrane which lines the lung.
Yeah.
That's the way I think of it.
Viscera means organ, right? I think.
Yeah.
So it lines the organ and the organ is the lung.
Yeah, perfect. What about the parietal pleura?
Well, that's in contact with the parietal layer.
Yeah, so that lines the thoracic cavity and it's usually a bit thicker. And it's important to know that it can be subdivided into 4 different sections. You've got the mediastinal, the cervical, costal, and the diaphragmatic. Not in any particular order, but just know that the parietal pleura can be subdivided into different sections based on the location. And then what do we have in between the visceral and parietal pleura? What is that called?
Space.
Yeah, the pleural space. And that's usually filled with a small amount of serous fluid, which helps lubricate the pleural cavity, helps reduce the friction. Does that make sense to you guys?
That's something else, doesn't it?
Well, probably does, but we're just going to keep it at that. It helps to reduce friction and lube and causes.
It sticks the 2 sides of the walls together, like by surface tension, so that moving one area changes the other area.
Yeah, I guess. Well, I just thought about it mainly as lubrication, of course.
Okay.
And the last bit of anatomy, which I wanted to go through, were spaces called the pleural recess. Does anyone know why they called that or what that means?
Is what you mean, Jason, that the shape of the lung does not stick perfectly against the shape of the cavity, such that there's a break between the 2 sides of the pleura.
So it's just a space, which is not completely filled up.
Like a gap.
A gap.
Yeah.
Space. Okay. And the one you need to know about is called the costodiaphragmatic recess, and that's between the costal and diaphragmatic pleura, and it's also called the costophrenic angle. So those 2 are the same thing: costophrenic angle, costodiaphragmatic recess. And I'll explain the importance of that later on. Okay, so that's pretty much pleural anatomy done. So now we're going to go through what a pleural effusion actually is. It's an accumulation of serous fluid within the pleural space. And I also just wanted to throw in some other terminology. So the accumulation of frank pus within the pleural space, that's called an empyema.
Frank pus.
Of just pus, but anyway, I got some definitions.
What does frank mean? Frank's like big pus.
Of course you guys focus on what fucking frank means. So.
Yeah, obvious.
Because
like
it's frank hematuria.
Yeah, frank bleeding.
Oh, so it's macro.
Yeah.
Yeah, okay.
Yeah,
Yeah, just
okay.
obvious.
Yeah.
All right.
Yeah.
And while we're at it, what is serous? Like just clear cells?
Well, serous is, serum in the blood is clear. Like, I think that's where the relationship comes from.
Makes sense.
Hey, you guys really want to go down the first principles of every word.
No.
Just questions I have always had,
Any questions?
I'll be honest, my only issue every single time they talk about pleural effusion is what's the difference between that and pulmonary edema.
Jason, let's go.
I didn't even talk about that. We'll discuss that at the end, I reckon, because that'll be a good subsection. But we've also got accumulation of blood within the pleural space, and that's called a hemothorax. Okay, so empyema hemothorax is similar to pleural effusion, but a bit different because the substance is different. The next thing I want to go through is that pleural effusion can be categorized into 2 different types: transudative versus exudative. So transudative effusion, does anyone know what that is?
That's when fluid is pushed through the membrane via increased hydrostatic pressure.
My man, he loves his first principles, okay? So it's essentially what Adian said. It's an imbalance of the capillary hydrostatic pressures and the capillary osmotic pressures. And if you guys remember Starling equation, that's what Adian is referring to. So an imbalance of those pressures cause fluid leakage. So there are a few causes which I want you to think about for transudative effusion. Can anyone think of what would cause those imbalances?
Increased production of fluid.
Yeah. So what leads to excess fluid?
Fluid retention,
Yeah. What causes fluid retention?
heart failure.
Heart failure. That's a very common cause of transudative effusion. What else? There's another organ which can fail and can cause fluid buildup.
Liver or kidney failure.
Liver failure. Yeah. Kidney, our favorite syndrome.
Nephrotic?
Yeah.
Nephrotic
Oh,
syndrome.
okay.
Yes.
You're
Okay.
asking.
So heart failure.
Is that our favorite syndrome?
Oh, that's my favorite
favorite
syndrome. Yeah. So does that make sense?
Mo, do you want to give us a little summary? Prove you pay attention.
I mean, from what I'm getting, transudate is obviously fluids leaking into a space, and that's why it's called transudate, transfer of water. And in this case, because it's transfer of water, it's most likely because inside of the original capillary, there's a low amount of protein, and to equalize everything, water is flowing out and into the other space, that way distributing the amount of water so that it's equal on both sides to make up for the low protein.
Yeah. And what are subcommon conditions which cause that?
The common conditions would be liver failure causing the low protein, or excessive water being heart failure from the fluid overload,
Yeah.
kidney failure, the limited water excretion, and the other one I forgot.
Yeah. No.
That's pretty good. It's more than I remember.
So nephrotic syndrome is kind of like kidney failure. Yeah. So liver failure,
Yeah,
heart
that,
failure,
yeah.
and nephrotic syndrome.
Yeah.
Okay.
Yeah.
So now moving on to the next type, we've got exudative effusion. And this is an effusion caused by increased vascular permeability due to inflammation. So can anyone think of causes of exudative effusion?
Pneumonia.
Pneumonia, right? That's under the infection, and that causes a special type of exudative effusion called parapneumonic effusion. So when you say someone's got a parapneumonic effusion, you mean it's a effusion caused by pneumonia. So that's an important thing to know. So there's another important infection which can cause exudative effusion. Can anyone think about it?
TB.
TB. Yeah, my man knows his
That
thing.
Dan's on fire
He
today.
loves his effusion. Good. So TB and pneumonia, those fall under the umbrella term of infection.
What do they infect the pleura, or they cause inflammation of the pleura and then the protein leaks out?
I kind of view it more as inflammation causes a change in the permeability.
It is leaking because the spaces are bigger, so
Mm,
things
mm.
can leak across.
Whereas the trans is more.
Water is being forced across.
Yeah, so transudate is more osmotic kind of
Mm,
hydrostatic
mm.
pressure.
Yeah.
Yeah. Okay.
Malignancy. Such
Yeah,
as
malignancy.
mesothelioma.
Dan, mate. Yeah, 10 out of this is a
You-
HD
mate, did you
student
did you
right here.
prepare? Swear to God, you prepared,
I
Daniel.
didn't even know the. No one
Son
tell me
of
the
a-
bloody
So
topic.
infection, malignant disease. Come on.
Embolism.
Sorry?
Embolism?
Yeah, pulmonary embolism.
Nice.
So 3. Come
Mo's
on.
up there. Mo's up there.
There's more
Yeah, there's 2 more.
categories.
Yeah, 2 more categories. Think of your vitamin. So
Really?
autoimmune
Autoimmune?
disease.
Yeah.
Oh,
That's
okay.
a common one. And
Wow.
the 2 main ones from autoimmune diseases, can anyone think? Yeah, SLE, rheumatoid arthritis. But if you just
Well,
say
that's a-
umbrella term autoimmune diseases, things
Yeah.
like SLE, RA, increased risk of exudative effusion. And the last one, which is a bit unrelated, it's an organ below the diaphragm. Can anyone think of it?
Stomach, spleen.
No, you're nearly there, but
Pancreas.
yes, pancreas, right? Because acute pancreatitis can cause
List
a lot
all
of
the organs.
inflammation,
Who's
and
giving
that
me
can
clues?
actually be a cause of an exudative effusion.
Just pancreatitis?
Acute pancreatitis.
Is that because it's a systemic inflammatory thing? Or
Yeah, probably. Sounds right.
Are we talking about a pleural effusion due to
Yeah.
the pancreatitis?
Yes.
Yeah. Okay. Cool.
Why? What did
That's
you think?
what the whole topic's about pleural
I
effusion,
just
Dan.
wanted
If
to
you haven't
clarify,
been
because
listening.
otherwise we can get exudates elsewhere. But
no,
that's
no,
good.
no.
No,
Just
we're
the
talking about
lungs.
pleural
Yeah.
effusion.
Not
okay?
interested in anything else besides
Yeah.
the lungs right now.
So the transudative versus exudative effusion, it's an important thing to be able to discriminate between those two things. And the way we figure out whether something's transudated or exudative is through a criteria known as Light's criteria. Does anyone know what that is, or do you want me to just go through that?
Dan knows.
No, I don't.
Well, the reason why I wanted to do this topic was that I've been on wards where the interns have told me that this is a common OSCE topic. And for
Okay.
some reason, Light's criteria is just an easy thing for them to be able to mark you on.
Gotcha.
Like, it's like, can you explain what the difference between transudative and exudative? Like, it's just very easy.
High yield.
Let me just
reckon.
whip it out on MD Calc or something.
Yeah, there are 3 main things which make up Light criteria. So a pleural effusion is likely to be an exudative effusion if the pleural fluid protein to serum protein ratio is greater than 0.5. The pleural fluid LDH to serum LDH ratio is greater than 0.6, or the pleural fluid LDH is greater than 2/3 of the upper limit of normal serum LDH. I know that's a bit of a mouthful, okay, but it's
we
easier
will have
once
this
you...
on the Notion page. Don't
Yeah.
worry.
Once you look at the Notion page, it's a lot easier to understand. But essentially, the first point about the serum protein versus the pleural protein, basically there's more protein in the exudative effusion compared with the transudative effusion.
You had a question, Mo?
I was just trying to figure out, LDH is lactate dehydrogenase?
Yes,
Okay.
LDH refers to lactate dehydrogenase, and that's an enzyme which is normally inside of cells in the body. However, when there's damage to the cells, the LDH leaks out and becomes part of the effusion. Or to further summarize and make it really, really simple, exudative effusion is high in protein and LDH compared with transudative effusion.
High as in it's high in the
Yes.
pleural fluid.
The pleural
Not
fluid.
the blood. Okay.
The pleural fluid. Yeah.
And it just has to satisfy any one of these criteria for it to be exudative. Is that right?
I'm not sure. Not sure
Okay.
exactly.
All right. Sure.
Yeah.
Hey guys, just some fact checking. So for Light's criteria, you actually just need to meet one of the 3 parameters that are stated for it to be classified as an exudative pleural effusion.
Yeah, that's
Of
essentially
the
it. Yeah.
expected levels. Yeah.
Because basically with the Lights criteria, you're comparing the protein which is in the pleural fluid, which you've aspirated,
Yeah.
versus in the blood. Sound good?
Sounds
Yeah,
good.
lovely.
So now we're going to go through a nice case to kind of consolidate this knowledge. So I want you to run through an assessment of a patient who's just come into ED. Okay. So let's imagine a 57-year-old male has come into ED complaining of shortness of breath after a recent chesty cough. What you going to do?
Let's go, Mo. Let's go.
If
What's
you've
the
been
first
listening,
step?
you know what we'll do here.
Well, I mean, after the history.
No, before the history.
Ooh.
First mistake. Oh,
Before the history,
The
Come on.
first principles.
the first principles would be the A, B, C, D.
Hey. So A to E assessment, okay?
Yeah.
Brilliant. Then after that, what do you
I
do?
mean, after that, after we've ensured everything's okay, everything's sorted out, we take a history.
Yes. And for the history, it's important to know that pleural effusion is often asymptomatic. However, if they are symptomatic, you would of course get things like dyspnea or shortness of breath. Can anyone think of other things which you'd get if you're symptomatic?
Depending on the cause, you could have cough if they have
Yeah,
an infection. If it's like a heart thing or a liver thing, you could have edema.
Yeah. So a lot
Or
of
something
things
like
are
that.
relevant, right? So try not to
It
overthink
is.
it too much. Think of stuff which is common in respiratory exam, right? So if they've got a cough and sputum, that's probably important for determining like the etiology. You're probably thinking they may have a pneumonia. If they've got hemoptysis, maybe thinking, oh, like malignancy. If they've got fever, probably thinking some type of infection. If they've got night sweats, weight loss, that's always cancer. No. So this is drilled into my brain. And another thing you probably get is possibly like pleuritic chest pain because the pleural effusion probably caused some irritation. But
Like
keep it
pleural
general.
nerves.
So after history, what do you do?
Well, you go on to examination.
Yes. So there are specific exam signs I want you guys to know about. So let's go through inspection. What are the typical exam sign you would see with a patient with pleural effusion?
Respiratory distress, dyspnea or tachypnea.
Yes, perfect. Okay, that's on
Nasal
inspection.
flaring.
Yeah, so signs of respiratory distress, which is probably 4 or 5 different things. But
Would you check the trachea as well?
Yeah.
See if it's
No,
deviated or not?
that's on palpation, my friend. Okay, palpation. So what did you say?
You can see
that
tracheal
really?
tug.
Oh, you could see tracheal
Ah,
tug,
you
but then you
can't-
put your finger. It's midline.
Yes.
Palpation.
But usually, can you even see the tracheal tug unless you're feeling it?
So
Pulling
a sign
back
of
in,
respiratory
yeah.
distress on inspection is tracheal tug,
Yeah.
which you can see.
But the position of the trachea you can't tell until
Yes.
palpation.
So palpation. So JT said
No.
tracheal deviation.
Yeah, midline. Or
Now, 50-50 guess. Okay? If the
pushes.
pleural effusion is on the right side, let's say it's on the right lung. You don't know this yet, but let's say it's on the right
Yeah.
right lung. Does the trachea move towards the effusion, like on the right side, or does the trachea move to the left, away from the effusion?
Left, I
think
reckon.
it's to the left
I reckon it's
because
the
there's
left.
stuff in the right, and
Away.
it pushes it to the left.
Yeah.
Yeah. So the trachea deviates away from the effusion. So there are 2 other things that you want to look for in palpation. Bring it back to very basic. Come on, man.
I was going to do upper lobes,
Is that palpation or is that inspection?
That is palpation.
Yeah.
Oh, your back. What are you doing?
Come on, what is this?
What is
Sorry.
that posterior?
Symmetrical lung
The lower
inflation.
lobes.
So reduced chest
No,
expansion.
that's the thing at the back.
Yeah, the lower lobes.
Yeah.
Oh, okay.
Yeah.
Oh, is that the lower
Centimeters
lobes?
apart.
Oh, okay, cool.
So assessing chest expansion. So you get reduced chest expansion on the infected side.
Okay.
What's the last thing? This is related to the cardiovascular exam, okay? What do you palpate on the cardiovascular exam?
The heart.
Yes? What do you
Oh,
mean
really?
the heart? You don't palpate the heart, do you?
The apex beat?
Yes. And that would be displaced away from the effusion. So if there's a pleural effusion on the left side, that could cause the apex beat to be displaced.
I don't know where it is.
Okay,
You know,
next one.
In all my years, which is 1.5, or one really, I've never felt an apex beat on a patient. Never.
You're not doing it right. You don't have the feel, mate.
No,
you gotta
never
have the
felt.
touch. Okay.
Just feeling your own.
I can
pulse
feel
rate.
myself, but I can never feel anybody else's.
Okay,
apex.
so now moving on to the next one, percussion. This is, in my opinion, the most important sign because it's pretty much pathognomonic of pleural effusion. I haven't seen any other causes of this particular sign on percussion.
Very bold.
Okay.
Stony dullness.
Yes, okay. So stony dullness over where the fluid is. I don't know what the hell that feels like
Well, have
or
you
what
felt,
it sounds
felt
like.
stony dullness?
No, I just read it on the
Yeah.
book.
I remember some clinician
Yeah.
telling me that apparently it's more like with the feel, not necessarily the sound.
It
it
feels like
produces.
stone.
I don't know, but
Mm.
stony dullness equals pleural effusion in my mind.
Mm.
Okay. Next, we're going to move to auscultation. So there are 4 signs I kind of think of. Can anyone think of those?
Pleural rub.
Yeah, pleural friction rub. I don't
Can
know
you
what it
hear
sounds
that?
like, but I don't know how to describe pleural friction rub. Like all
Yeah,
these sounds
like-
are so
like
difficult
when
to
you go-
describe.
Yeah, just do it to the mic.
Here we go, Aiden. Put it in.
Pleural friction rub. Yep. Anything else?
Reduced air entry into the affected area.
Yep. So reduced or absent breath sounds.
Crackles on the edge, but not at the fluid, I believe.
So you
Not
get
the fluid, I don't think.
you get bronchial breath sounds, which are present above the level of the effusion.
Oh, that's what I meant.
But the
Yeah,
real one I wanted to go through was vocal resonance. Is vocal resonance increased or decreased? Daniel, you look very excited to answer this question.
No, I'm having a thing. I can't remember. I think it's decreased, but I can't 100% sure.
Yes. So there is decreased vocal resonance with the pleural effusion. And the reason why I bring that up is that it's an important discriminator between pneumonia and pleural effusion, in my opinion. Because pneumonias often increase the vocal resonance because when there's consolidation within the lung, that solid matter helps to conduct the sound.
Yeah.
But because pleural effusion, the fluid is over the lung, essentially, that has the opposite effect. Okay? So reduced vocal resonance. Isn't that cool? Come on. Okay. So now that we've done our clinical assessment, we're going to go and investigate the causes. So what are the investigations we're going to do? Starting off with bedside investigations.
Let's go, Mo. Let's go.
I was going to say needle into the lungs.
Straight away. High yield. Go straight for the
Because
high yield.
the thing is, though, when you've got an OSCE, like, from my understanding, they're going to be like, now, what would you do next? I would start off with bedside investigations,
Okay.
including...
Bedside, you'd go ECG,
Yeah.
make sure you rule out any cardiac
For sure.
factors. Urine sample to see urine output as well as if there's an infection.
Yeah, so ECG, urinalysis, what else?
Take the temperature.
Temperature, very important, fever,
Blood glucose.
blood glucose.
Would you get protein in the urinalysis?
If it's a
If it's a nephrotic cause.
Oh, right.
Yeah. And another important thing was
Yeah, yeah.
oxygen saturation.
Mm.
Because you want to see how acutely unwell. Yeah. So these bedside things, like, don't overthink them. Like, think about it logically. It's always the same kind of stuff. ECG, oxygen saturation, temperature, blah, 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 blah. Okay? So now moving from the bedside investigations, we're going to go through, like, the laboratory tests. So what are the general bloods you're going to order? Spit them out.
FBC.
Yep. And
So-
what are you looking for in FBC?
So you're looking for signs of infection.
Yeah.
Looking for anemia as a possible cause of his
And what's the
distress.
sign of infection on
raised
FBC?
white cells.
Perfect.
CRP, raised inflammatory marker.
Yes. So full blood count and CRP,
Mhm.
those are 2 separate investigations.
Mhm.
What's the next one?
FTs,
LFTs. Why?
because we said liver failure can cause
Yeah.
a transudative effusion.
Would you get an amylase to rule out pancreas?
Yep. So I think that's more like if indicated.
Mm.
So we'll go through that in a sec. So full blood count, CRP,
Then
What's another?
EUC or UEC?
UEC? Yeah.
UEC. I always get them around.
Mhm.
And why would you do that?
For kidney factors, issues.
Kidney baseline function. Yeah, just so that I always think of like full blood picture, CRP, UEC, LFTs are your kind of general bloods. Okay, now we go through like specific investigations if they're clinically indicated. So you mentioned lipase.
That's the one.
So why would you do a lipase?
For acute pancreatitis.
Yeah, so exactly. If you're suspecting acute pancreatitis, you do, of course do a lipase, right? What else?
If you suspect they had an MI and heart failure secondary to an MI, do troponin,
Yeah, why not?
cardiac enzymes.
And
Makes
BNP
Yeah,
for heart failure.
Lactate as well for sepsis.
yeah.
We
yes,
have to
right?
do it.
Actually, yeah, if we're going to use Light's criteria, we have to get the serum lactate, right?
Yeah,
That's a good point, yeah.
I didn't really think. Yeah,
Some high yield right
That's
there. Mo.
exactly what I meant
Yeah,
by
yeah,
saying
yeah.
And we're
But-
gonna do that needle biopsy,
We're
fluoro.
still going on.
mate, this is
Isn't that specialized?
this is a laboratory test first. We'll go through the.
Isn't that lab
test?
Sorry.
That is a lab test. I mean, getting it is a bit more difficult.
Anyway, we'll go through. I consider that more
Jason
invasive
looks at it,
procedure.
it's like, oh, yeah,
Okay.
that
So we've
looks
gone.
like it to me.
We're going through bedside laboratory tests. So the other things I've thought of is like sputum, MCS
Yeah.
to see what pathogen, autoimmune markers, which would
Yeah.
include what? Can anyone give
Jesus.
quick example?
DNA,
Yeah.
double-stranded DNA.
Yeah.
C3, C4.
Yes.
Some anti-Smith.
ANA, rheumatoid factor.
So,
Yeah. Oh, ESR is a good one. I've totally forgot about
we
that
don't need
one.
to go to antibody tests because
Anyway,
Mm.
the point of
Get the specialist in.
what I was just
Yeah.
saying, if it's indicated, things like autoimmune markers, lipase,
Mm.
are valid tests,
Oh, yeah,
right?
everything's
But you just have to,
indicated.
you just have to
Can
say
be
that.
indicated.
This pleural effusion, we don't even know what the cause is.
Yeah, but
General pleural
you often
effusion.
get the cause of things through the history and exam,
True,
JT.
true,
Jeez.
true.
Ooh.
Thank you.
Okay, so we've gone through bedside.
Yep.
We've gone through the laboratory tests. So now we'll go through imaging. What is the imaging test you're going to do?
Plain
Chest
film
X-ray.
checks X-ray. Yep, that's the one.
Yeah.
That's the one.
Surely.
So what angle though? You got to
Upright AP or PA.
yeah, and
Then
what?
do a lateral, you might as well. Or
Yeah.
Mm.
So a PA chest X-ray, and now we're going to move on to another very important sign. So what is the key imaging sign on a PA
Blunting,
check?
blunting of the costodiaphragmatic angle.
Yes.
Hence the upright chest X-ray.
that's why he mentioned it.
Perfect. So blunting of the costophrenic angle, or as Aideen said, the costodiaphragmatic recess, is a key sign of pleural effusion. And this is caused due to the presence of the effusion, causing loss of adjacent aerated lung for contrast. And it's important to know that usually the costophrenic angle is sharply defined, but when there's a pleural effusion, it looks blunted.
because
Okay?
there's fluid there. and it
Yes,
doesn't
because
have
there's fluid.
Okay, yeah, easy.
And another important thing to know is that it's usually only on a PA X-ray when the effusion is greater than 200 milliliters. So if it's quite a small pleural effusion, it's possible that there is a pleural effusion there, but it's just not big enough to be visible on that type of imaging. Remember that. Another key sign on a PA chest X-ray is, does anyone know, first of all?
The fissures?
No?
Deviation of the trachea away from the affected site.
Yes, that's one. It wasn't the one I was talking about, but tracheal or / heart border deviation away from the fusion is another sign of pleural effusion on an X-ray. The sign I was asking for is called the meniscus sign. Okay, has anyone heard that?
Oh, it's just the fluid, and then, like, I guess when you go back to basic science class, you see the meniscus in a test tube.
It's like a little U, like a
Yeah.
Mhm.
shallow U.
And then you see that on the chest X-ray. I believe.
So it's a water-dense shadow with curved concave upper border. But that's kind of hard to imagine, so that's why we've got the Notion document and the Ankies, okay? To look and see what unilateral blunting of the costophrenic angle and meniscus sign looks like. Another imaging, which it's called a lateral decubitus chest X-ray. So that's pretty much a chest X-ray when you're lying on your side, and that is supposedly more sensitive for detection of fluid collections than a PA chest X-ray. Okay, and the last
this the
imaging,
same,
can
like-
anyone guess what that is? It's not X-ray.
CT?
No, not
Ultrasound.
ultrasound,
Yeah.
right?
Yeah.
So that's really useful for confirming the
'Cause
effusion
it's fluid.
and for also planning the aspiration later on, because
Mm.
ultrasound's quite quick and easy to do
Mm.
relative to other imaging. So now that we've gone through the bedside, the laboratory tests, the imaging, we're going to go through the invasive investigations. So there's one
Let's go, Mo. What's that?
one
What we
classic
doing?
one.
What we
You've
doing?
been waiting the whole life for this.
Stick a needle in.
Yeah, stick a needle. Okay.
But
Or-
what's it called?
Ultrasound guided pleural fluid aspiration
That's
and
wrong.
analysis.
Yep.
Or stick a needle.
Is there like
Wait,
a
wasn't
one-
it called thoracentesis? Is that
Yes,
is that what I'm thinking about?
Yeah.
Okay.
it's also called thoracentesis, but in my mind, it just makes a lot more sense to say pleural fluid aspiration.
How?
Because in an exam, am I going to remember the exact word for pleural fluid sampling?
That's
I guess you should be, yes.
By the time you finish saying
You wouldn't
that,
say
you're
like
on time.
cut up half the bowel for a partial.
But I'll just forget what the word is. I'm going to remember in an exam,
Remember-
I'm going to aspirate the pleural
I
fluid and
remember
analyze
I'll
it.
stick a needle in that.
Can you say FNA?
Fine needle
Fine
aspirate.
needle aspirate?
I don't know. If
I'm not sure.
Pleural fluid?
I
I'm
don't
not
think
sure.
that-
Isn't that only for like
I know we
breasts
just
and
say-
like lumps?
Well, yes, I'm just wondering if it's interchangeable.
I'm
I
not
think it's
sure.
different. I think that's
I'm
more
not
like a
sure.
Because it's a
biopsy.
fine needle.
I think this is a lot more, like you get a lot more
Could
fluid.
you like full syringe it out? Right?
Yeah.
Whereas the other one's just like a pull it out.
It's a cool thing to watch when you see them because you
Is
get them
this
to
the
like.
same thing with like ascites? Because you know ascites, we
Ascites.
want to turn them around on the lateral side to test for the shifting dullness,
Mm.
right? So is it in the same principle? You're trying to shift the fluid.
I don't know. I just
X-ray.
read this.
Probably with that lateral decubitus thing.
Yeah.
Maybe, yeah.
Yeah.
I
And
just
then,
read
and then
that
while
that's
you
more
aspirate,
sensitive.
you also turn them to their side, don't you? Or
No,
you know,
no,
or you
What
let
do
them
you-
lie on their back. Or,
no,
or-
no.
huh.
I've seen them do the aspiration. Usually, you get them to sit on the edge of a bed and
Mm.
kind of lean forward.
Oh, okay.
But I'm not
Do
sure
they
on the
go
technique
from the front or the back?
from the back.
Mm.
But I
So they
imagine
do
they'd
it from the
be, they'd
back.
be aiming for that costodiaphragmatic
Yeah,
recess
okay,
with
so-
the
Yeah.
juicy spot, right?
Yeah. Oh, and that's by gravity then.
Okay, so when they get the fluid, so they aspirate this fluid out of the pleural space, and then they analyze it. Okay, so they analyze like the biochemistry, which looks at the protein, glucose, pH, LDH, amylase. They look for any bacteria which is in the pleural space. So you do the MC&S on those. You look for cytology, like what cells in there. You also look for immunological factors such as like rheumatoid factor ANA. But essentially, I think for us at this level, we just need to know Light's criteria.
I
Yeah.
think that's the best to remember.
Yeah,
Yeah.
because otherwise it goes way too in depth with the
Yeah.
different types of
For sure. I'm still like 20 minutes ago.
yeah. And there's one other invasive investigation, and you do this when the fluid analysis is inconclusive. Can anyone think what that is?
Should take a biopsy.
Yeah, a biopsy of the pleura.
Oh.
Okay.
Why is
Pleural
that?
tissue.
Well, maybe
Wow.
that's the cause of it, or I'm
Oh,
not
so to
particularly
do
sure.
whatever
It's
they
not
say.
a
But if
lot
the
to
fluid analysis,
biopsy.
like they still can't really figure out what the cause of it is,
So
then they
ultrasound
just do a biopsy of the pleural.
It's hella thin, no?
Well, if it's inflamed, it's probably a bit thicker than it should be.
Wow. Okay.
Do they always use an ultrasound to do it as well?
Probably. Yeah. I assume they do that. Yeah.
Nah,
I think.
just going by feel, man.
Yeah. So I think the pleural biopsy is probably ultrasound guided.
Yeah.
But,
Or ex-
you-
ma-
but
economic.
50 years ago, who knows, man? They probably just
I
did
mean,
it
yeah.
based off feel and touch.
Technically, you can, right? Because people, when you cannulate,
Probably, yeah.
you can feel when you.
Just
press
because you
the-
technically can doesn't mean
No,
you
I mean,
should
like,
do
you,
it.
you see,
No.
you see like spinal blocks. It's just like, yeah, that feels like where the space goes, and you just stick a needle.
I mean,
Yeah,
but you
yeah.
can test it, like, because fluid comes out, right?
No,
it's
they
like-
feel a pop.
But the idea behind like, can you trust your anatomical knowledge so much?
That's
You ain't
that's
gonna
something which
like-
scares me.
Freaking
Yeah.
alpha vertebrae.
Uh,
I'm feeling the spinous here.
So yeah, investigations are done, right? So now we're just going to go briefly over the management. There are two key steps. Okay, what's the first step?
Treat the cause.
No, before that,
Identify the cause.
Stabilize.
No. therapeutic drainage of the pleural effusion.
Symptomatic relief.
Yeah.
Is that what you think?
So you just drain the fluid.
Okay.
Or I don't know how much they drain, but I would say therapeutic drainage of the pleural effusion. Okay. The next thing, what Daniel said, was treatment of the underlying cause. So that's why Light's criteria is very important, because it can help you figure out what the cause is in conjunction with the history and exam. So you're done. That's management done.
Is pleural effusion an acute thing?
I think it depends on the cause. Sometimes
oh,
it can
okay,
just
fair enough,
gradually
yeah.
build up, or sometimes it can be
okay.
a major event.
And I assume you'd only drain it if the patient's in, respiratory distress or something.
Yeah,
Yeah.
Like anything, you got to weigh up the pros and cons.
Lovely.
Okay. The three key takeaways I
Yeah.
wanted you guys to learn was pleural effusion can be classified into exudative or transudative effusions based off Light's criteria. Stony dullness is the key exam sign of pleural effusion. And lastly, unilateral blunting of the costophrenic angle is the key chest x-ray sign of pleural effusion. I reckon if you know those three things, you can sound really smart at least. You may not know what all those things mean, but you'll sound smart.
What? So they
Okay.
ask you about kidney failure. It's like, let me talk to you about pleural
Yeah.
effusion.
And light's criteria, it's kind of hard to say over the podcast, but if you just look at the Notion page and the Ankies and just learn those numbers, you'll be fine.
Or go to mid-calc and look up light's criteria as well.
Yeah, you should just know it in your head.
Now, in your OSCE, that's a good question. Let me just pull up MD Calc.
Yeah.
Light's criteria for you,
I'm
buddy.
just going to Google it during the OSCE. That's a reality, though.
You'd say, I would confirm this,
Yeah.
but...
I'd refer to therapeutic
Yeah,
guidelines.
in fact, watch me confirm it right now.
Does anyone want to quickly run through what light's criteria is?
Yes, I
Yeah.
remember.
Let's go, Mo.
I remember the numbers.
Let's
Okay.
go, Mo.
Let me-
0.5, 0.6, and 2/3.
Yes.
Lovely.
So 0.5 is when you're comparing pleural fluid protein to serum protein ratio.
Yep.
0.6 is pleural fluid LDH compared with serum LDH ratio, and pleural fluid LDH greater than 2/3 of the upper limit of normal serum LDH. Those are a few things you just have to remember.
I
Like,
just remember the numbers.
there's no other. 0.5, 0.6, 2/3, and exudative effusion is like, yeah, they have higher levels of those two.
0.5,
Zero.
0.6, 0.6.
That's actually pretty good. Yeah.
It's a good one. It's quick.
Yeah.
Cool.
Cool. Any questions, Dan? Come on. Surely I've got something wrong with you wanting to comment. Come on, say it.
No. It's all good. It's all good.
Awesome. So thank you very much, guys. We are now on multiple podcast channels. So choose your podcast app: Overcast, Pocket Cast, Apple Podcasts, Amazon Music. Not YouTube Music yet, but love to see you there soon. See you guys soon. Bye-bye.
Thank you so much for listening to our episode this week on 1pm. Feel free to check out our Anki flashcards and our Notion document. You can also check out 1pm.wiki for more information. We'll see you next time.